Welcome. It's 1 o'clock and I promised I would start sharp. So that's what I'm doing. Welcome everybody. My name is Ayla and I would like to welcome you to this workshop on shared decision making using real world evidence. The question we will be discussing today is how can patients and healthcare professionals do it? We are delighted to have a great number of interesting speakers today. As you all have seen on the program, we get to hear and learn from Wim Goettsch, Holger Schunemann, Konstantina Chalkou, Ivett Jakab, Amr Makadi, Marinella Offerman, Javier Paul, Li Fang Lu, and Gemma Garcia Saez. After we have heard all their inspiring talks, it's time to get active. Céline Duché is a user experience designer and researcher who will guide you through an interactive workshop, prototype a tool for shared decision making. It might be a little bit outside of your comfort zone, but if you have the possibility to stay for this part, I really urge you to do so. It will be such an eye-opener to the difficulties and chances that come with using such information to make good decisions. To prepare for this workshop, we have asked all registered participants to communicate to us in which disease-specific group you would like to take part. If you came to this workshop last minute or just didn't have the time to fill out the short Google form, please do so now or in the break, and I will put the details to this Google form in the chat. Before we start with this workshop, I would like to share with you why this matters to me personally. Until a while ago, organizing this workshop was just part of my job. But unfortunately, my mother got cancer. She received immunotherapy, and although it did reduce the size of the tumors, it also caused her to have severe heart failure, amongst many other side effects. Because the risk of the heart giving in was too high, the oncologist advised to switch to BRAF inhibitors. This drug caused other side effects, which led her to being admitted to the hospital 3 times in a couple of weeks. After this, she stopped the cancer treatment herself, despite the oncologist assistant coming to her in the hospital to talk her into continued use of the BRAF inhibitors. At that moment, we felt very lost. We completely supported my mother's decision to stop treatment until more was known about what was causing the side effects, but we would have been much happier if we had gotten more information on what happened to other patients and mostly could have talked to the oncologist in a neutral manner, not feeling pushed into using drugs that made her feel sicker. All in all, this workshop got much more relevant for me personally over these months, and I look forward to hearing the stories of all the speakers today who will probably recognize the story in one way or another. A last practical matter is the fact that the part of this meeting before the interactive workshop takes off will be recorded and may be distributed to interested people on request. You may ask a question or a comment in the chat. We have a very packed program and therefore may not be able to respond to all the questions direct, but you can always take them into the interactive workshop where there will be more time to discuss them. But therefore I will be rather strict on the speakers to keep to their time slots, and to prevent running late in the first minutes, I would like to give the floor to Wim Goettsch, the first speaker of today, who is the project leader of HDX.
It puts the things which we try to do here in a great perspective. I will actually want to give a short introduction on the HDX project, and I will try to share my screen. One moment. See. I hope you can see my presentation. A little bit bigger, I hope now.
No, I don't see it yet.
One moment.
There.
And now?
Yeah, great.
Great, thanks. So what I would like to do is just say a few words on the project, but first I would like to welcome you all. I think it's great to see how many people over here and have such an excellent session with excellent speakers. And I really want to try to be humble today, because I think what we try to do with this project, with today, is really to provide aware that what we do may provide a little bit of support, but I think for today, it's really to hear from the speakers what their thoughts are, and I'm also very actively looking forward to
woensdag 15 December.
Sorry, I think somebody still has his microphone on. And would like to also discuss a little bit the introduction on the project. So I think that some of you have been introduced before to this project. It's an Horizon 2020 project, which is being already there for a little bit less than 3 years. And we are a group of academic organizations, of HCA organizations, but also of involved state organizations. I will say a few words. For this project is to create a framework for what we call next generation health technology assessment, which really aims for this what we call patient-centered, social-oriented, real-time decision-making for integrated healthcare throughout Europe. And we try to do this by actually supporting development of methodologies, which actually could provide more customized information on effectiveness and cost effectiveness of complex and personalized combinations of health technologies. And I think today is I think the focus, a third goal of our project, that if we actually develop those methods, can it also support personalized treatment? And we want to discuss this today. And finally, also, it's important for us to see how these methods actually will land in the European practice. So with the HA organizations, with the clinical practice, and with all other stakeholders involved. So this is also a slide where we actually try to indicate that what we try to do within this project is about the learning healthcare system, about data and infrastructure, and that there is a quite significant focus on all kind of different method development, advanced analytics, methods using real-world evidence, systems which will get rapid updated. So if you have those systems available, can they also provide feedback to HA organizations, but maybe also to clinicians and patients quickly, and we don't have to wait for months or even years to use those data. But it's also about, if we have these kind of methods, how do we interact with the stakeholders? And this is also clearly indicated in this picture. So I won't go in detail in the methods. I think some of these methods will be discussed later on by some of the participants. Some of our consortium members will say a little bit more about the specific disease areas and what they're currently doing in terms of development of methods. But in shortly, it's about prediction modeling, where we use different types of data. And subsequently, if we have this kind of prediction modeling, can we also translate this to health economic? So not only looking at facts, but also at the costs. And finally, and I think that also relates to the last part of this program, can we actually make use of new methods like artificial intelligence and machine learning to help forecast individual patient treatment outcomes? And I think within our project, we also try to focus a little bit on what we call combinations of sequences of health technologies, which quite often are not evaluated in RCTs as such. Well, we have case studies, and I think these case studies will come forward in today. We have a case study about proton therapy in head and neck cancer, one on diabetes, which will be in the case study and also subsequently treatment modalities in patients with myelodysplastic syndrome, which is a kind of example of more what we call a rare disease. And what is also crucial that we want to actually think about, well, if we develop those methods, can we actually link them to a kind of framework so that we would generalize results? maybe to different patient populations, to different geographic settings, but could also the methods development as such also helping other disease areas, other technologies to do similar things. So what is our focus? As I indicated before, it's about combination of health technologies and how can different data sources support assessment of combination of health technologies. And what kind of data sources do we talk about? Is it about large-scale registries? Is it about claims databases or about pragmatic trials? What can we do? And I think, again, that relates very clearly to what we discussed today. Individualized or personalized treatment decisions. Can we actually use combinations of different types of data to support prediction of preferred treatment for individual patients? And can we then subsequently also, if we do this, try to adjust for, well, for instance, background profiles of the patients, for instance, doing prognostic modeling? And finally, also, what can we do with treatment pathways? Because we quite often see that, for instance, new health technologies are tested in a certain setting, maybe in a first-line setting or second-line setting, maybe also only if they have had a certain treatment in the first line and then actually in second line. What can we do actually to bring different data sources together to actually have more adequate data on treatment sequences? And can we actually provide also simulation models that help to predict the optimal treatment pathway?
You've got 2 more minutes, Wim.
Okay, I'm nearly there, so that's good. And that's both from the data synthesis perspective as well from the perspective of artificial intelligence and machine learning. And again, today will be a lot of focus on this second bullet point. So just to say a few words, and I think that I see Matteo Scarabelli from Eurordis also in the room. I think this kind of role to patients, I think this is just a picture taken from our website about how patients get involved in this project. And our partner Eurordis have been quite actively to facilitate this kind of activity, really already from the beginning to, for instance, interacting patients with the people which are developing the methods, or interacting in the methods workshop, which we had quite recently, to really ensure that there is not a very significant disconnect to what is actually developed by academics and what it will be needed by patients. And I think just to give you a few examples, I think this was already an example from quite early in our project when we still had the option to travel, have these kind of interactions where the patient partners actually went to our partner in Oulu, which is very important in generating these new methods using artificial intelligence and machine learning. And this is another example where people from H6 actually participated in the Eurordis Summer School in Barcelona in Spain. And I think that shows that we have trying to involve this patient perspective early from the beginning. Sadly, also due to COVID, we were less capable to have actually this live interaction, but we feel that workshops as today are very important for our project. So therefore, I would like to finalize my presentation. And I'll just say a few words. I see I have a last slide where we think this will relate to discussion today. For instance, how to pick the right patient-reported outcome, and what can we do about determining the outcome measures, head and neck cancer, proton therapy, diabetes. What can we do to facilitate interaction between stakeholders, health technology assessment bodies, clinicians, industry, but also patient-reported, also patients, providers, and how can we include the reflections of patients, and discussing what can we do with new methods and how do these methods actually provide practical and reliable tools. And finally, how should data be used in interaction in shared decision making? What would be the interactivity? And I think that interactivity, which we have later in day, might also give some thoughts about how will we use data from electronic health records, what about privacy concern, how to use patient registries, etc. So I'm really looking forward to the workshop, and I would like to give the floor back to Ayla for the next part of the program. Thank you.
Thank you, Wim. Thank you for your concise introduction to HTX. I would like to ask Holger Schunemann, to start preparing his slides, share his screen. Holger Schunemann is a co-chair of the GREAT Working Group and director of Cochrane Canada. He's trained in internal medicine, epidemiology, and preventive medicine, and he has co-authored over 700 peer-reviewed publications and has been named by Thomson Reuters as one of the most influential 3,000 scientific minds across scientific disciplines in 2015. So yeah, we have a very important speaker. We have 10 minutes for you. Take it away, Holger.
Yeah, let's get going. Not too much time on the introduction. Yeah, thanks very much for having me. Really excited to be here. I'm going to talk about the evidence ecosystem and focus on health decision making in this context. I'm dialing in from Hamilton, close to Toronto in Ontario, McMaster University. These are my disclosures. I don't have any direct financial conflicts of interest. Funding for the work that I will be presenting has been obtained from WHO, and there's lots of people who have contributed, and I would like to acknowledge them. So I'm going to talk about three different things today. One is the evidence ecosystem related to health decision-making contexts, and focus a bit on the overlap of guidelines with HTA and other disciplines, present a framework for thinking and working together that we've developed under the aegis of WHO, and then provide two quick examples for how this can be implemented. The problem obviously is that clinicians, the public, including patients, policymakers, payers, regulators, and the science community influence and make decisions. That is happening at various levels. And they use systematic reviews, health technology assessments, they use guideline recommendations, coverage decisions, they use essential medicine or diagnostic lists, and they are involved in quality improvement efforts, or they use policy or evidence briefs to make these type of decisions if they're evidence-based. However, the extent to which these different actors actually use structured processes and transparent criteria differs, and they are often poorly coordinated. That's the big problem. When it comes to asking questions about that inform health decisions, it's a few things that we think are obviously relevant. One, are the expected health benefits greater than the harms, or vice versa? And that integrates considerations about the priority and severity of the problem, the intervention effects, the values people place on the outcomes or patients place on the outcomes, as well as the certainty in these effects. The second thing is that I'm asking obviously about what is the magnitude of resource requirements. That includes costs and cost effectiveness. Next, we are asking what the impact of the interventions is on equity, including societal implications and possibly environmental impacts. Finally, is the intervention or strategy actually acceptable to different stakeholders? That includes patients, but includes other stakeholders as well, and it includes ethical and other considerations. And then finally, is the intervention feasible? And that criterion includes health systems, societal, legal, political, and other considerations in our view. So under the aegis of WHO, various WHO partners and the Estonian Health Insurance Fund, beginning early in 2019, we started working on this conceptualization of the evidence ecosystem with representatives of different areas. And we discussed how the evidence that influences these decisions and the actual decisions relate to each other, the factors that influence the decision, such as the ones that I just described. We also call them criteria, the type of evidence that is required and where it actually comes to play, who's making recommendations and decisions and in what context. And then the goal was really to lay out concepts of decision-making and then create bridges between these disciplines that really go beyond the traditional partnerships that we already have, although they are not great, always HTA guidelines and systematic reviews. And we used a couple of case studies that I will not go into here from Estonia and Cardiff in this context. Our starting point was work actually that we did from 2010 to 2015 on the evidence to decision criteria with the GREAT Working Group that are described in this BMJ publication. There were a number of other follow-up publications that describe these evidence to decision frameworks that we had developed with various partners, including WHO and NICE and so on, groups that are involved in health technology assessment, obviously. And what we prepared at that time were not only these criteria, but also we prepared frameworks that integrated different perspectives. And we obviously found that many of these criteria were overlapping between different decisions, such as coverage decisions and health systems type of decisions and recommendations. And we prepared tools for doing this, where these criteria were integrated, such as this GradePro tool that integrates these various factors and allows moving from evidence to a decision. And we started thinking about these different perspectives, clinical perspectives, the population perspectives that are more than individual perspectives, and started to utilize these tools literally now in over in several thousands of recommendations, primarily in clinical practice guidelines. But we also realized this is not enough, and here's our theory of everything, borrowing from the concepts of physics, where an integrative theory would bring together elements for decision making. And I will spend a little bit of time on this particular slide here. So the starting point is obviously that across disciplines, questions are formulated in similar ways. We use this population interventions, comparatives, and outcomes format, the PICO format that most of you are very much familiar with. And then there is evidence from primary research. This evidence from primary research through methods, we call it methods of systematic reviews, get integrated into these various different decision-making by different decision-making players. That includes HTAs and guidelines, but it goes beyond that. It includes quality improvement, coverage decisions, as I said, essential medicine decisions across countries, and we follow legal frameworks, including for evidence-informed policymaking. What became very obvious is that across the disciplines, these criteria here were pretty similar and used by all of them. What differs is that within the various decision-making contexts, there's different terminology used for similar concepts, oftentimes across the different decision makers, right? So, for instance, in quality improvement, we often talk about scientific soundness. We mean certainty of evidence. Feasibility has to do with measurability, and so on. So that at the end of the day, there is some overlap in many of these criteria, but not in all of them. And in part, it has to do with, as I already said, different terminology that is used. Modeling is used by most of these disciplines, and then conclusions are drawn in a transparent, sometimes not so transparent way across disciplines as well. For HTA and guidelines, this often leads to recommendations that then, again, through these other players, are utilized for decision-making. In evidence-informed policymaking, we often talk about options, and that obviously altogether becomes a product. There's another interesting player, and those are regulators. They may or may not use evidence from systematic reviews. As you know, regulator decisions are often made on the basis of a single or two trials or studies. All of that together has the same target groups as users. Those are clinical, public health, and health system type of users and decision makers. And what is important, I think, is implementation then leads to ideally more research. What I want to emphasize is that the primary research influences all of these criteria. There's systematic reviews on values, there's systematic reviews on costs, there are systematic reviews that actually address the problem of the importance of a problem, as well as for several of these other factors. And it's again, evidence from primary research, be it from randomized trials or observational studies, registries, it doesn't really matter. And that research, again, and this makes it circular, is then integrated in further decision-making. And I want to emphasize it's any research evidence, regardless of how it is collected. It's about assessing the certainty in it. You all know that I am in big disfavor of the term real-world evidence. Anything is evidence, right? And everything is the real world. So that's kind of the evidence ecosystem for health decision-making.
You've got 1 more minute, Holger.
Yeah, very, very quickly, I wanted to emphasize for which criteria In particular, non-randomized designs are important. They're hereby highlighted by the quotation marks. For instance, on values, we often use non-randomized designs. Decisions that are made can be collected through non-randomized designs. And again, the emphasis on all evidence being real-world evidence. Then finally, in my last slide, an example for how these disciplines can be bridged with regards to outcomes and outcome definitions. This is about the fact that at the center is obviously people or patients, and that different disciplines use outcomes that are related to what really matters to people. And the closer, the more direct the evidence actually gets, the more confident we are that we are addressing the right evidence. And the point is, again, this all can be assessed through looking at how, again, directly the evidence that we obtain in these various spheres by these various players, and how directly it relates to what matters to patients or the people. And in GRADE, this is covered through indirectness. But this is an example for how these different disciplines, from original research to systematic reviews, HTA guidelines, quality improvement, and other kind of care provision, can interact and work together. So thanks very much. Again, evidence ecosystem about health decisions. This is not only about guidelines and HTA, it is much bigger. We need these unifying frameworks. And I presented you very briefly with an example for how this actually can work with regards to outcomes, and where, for instance, agreement on definitions across disciplines is critical in order to move forward. Thanks.
Thank you, Holger. There was a lot of information on your slides, but I think the main message is that we need to take into the interactive workshop is that the information that is used for one decision will be used in other decisions as well. So keep this in mind when moving forward. I would like to ask Konstantina to get ready and present your slides. Konstantina will present an example of a tool that she has been developing. She's a PhD at the University of Bern, and she will explain what she has been working on. Go ahead, Konstantina.
Hello, thank you. Can you see my slides?
Yes, perfect.
Okay, perfect. So hello to everyone. My name is Konstantina Chalkou, and I'm a PhD student in the University of Bern. And today I will present you a tool for individualized predictions of treatment effects. And I will also show you an example on multiple sclerosis. However, this model could be used to any health condition. The idea is that our main question is which treatment is the best for a specific patient. Sorry? Based on an outcome of interest. We know very well that different patients often have different health outcomes under the same treatment. And also, nowadays, doctors have to decide between several treatment options. So here, for example, for schizophrenia, we can see that the treatment options available are several, like haloperidol, lithium, etc. And hence, we need to decide which one of these treatments is the best for each patient. So treatment choice is or should be personalized, as not all patients have the same response to the same treatment, and this is known as heterogeneous treatment effects. And the optimal treatment depends on patient characteristics. Let's see an example here. Here, patient A is a relapsing remitting multiple sclerosis patient. Here we can see on the left side that is a female, 42 years old, with a relatively low baseline EDSS, depicting a baseline less severe condition. And we can see that based on these characteristics, for this specific patient, dimethyl fumarate is the drug that minimizes the risk to relapse within the next 2 years, with 24.8% probability. And then natalizumab follows with 26.6% probability to relapse. Whereas for another patient with relapsing remitting multiple sclerosis, patient B, with different baseline characteristics. So again, we have a female that is younger, but with a much higher EDSS and different other baseline characteristics here. We can see that for this patient, natalizumab seems to be the best option with 58% probability to relapse, and then the methyl fumarate follows with much higher probability. Now, the idea behind our model is, I will present it here. Let's say we have 3 active drugs for relapsing remitting multiple sclerosis. So we have the methyl fumarate, glatiramer acetate, and natalizumab, and also we have placebo. Each one of these treatments give a predicted outcome. And what we want is to see this predicted outcome individualized for each patient. So we need to take into account the patient characteristics and also the relative treatment effects. So in the first stage, we take into account the patient characteristics using prognostic modeling methods to develop the risk score that depicts the probability of the outcome at baseline. And we can tell that this is the baseline severity of each patient irrelevant to any treatment. And then we use this risk score in a network meta-regression model to estimate also the relative treatment effects. So we have 2 stages, stage 1 and stage 2. And for the first stage, we use real-world data and more specifically an observational cohort to develop the prognostic model as real-world evidence depicts are closer to the real-world conditions. And in the second stage, we use randomized clinical trials with individual participant data and also aggregated data to enhance the relevant information. Now we can see the output of this model. Here is an R-Shiny app that you can also try, that is for patients with relapsing remitting multiple sclerosis. And here in the left side of this app, patients and doctors can insert the baseline characteristics of the patient. So let's say that we have a patient of 43 years old that is female, white, she didn't have any multiple sclerosis treatment before. And we here put all the baseline characteristics, like also years since onset of symptoms, and also some other exams that are very important for relapsing remitting multiple sclerosis. And then the output is this graph. This blue line corresponds to the patient, and we can see in the graph that the drug that minimizes the risk seems to be natalizumab because it has lower probability than the other drugs. And then the orange drug follows, and this is the dimethyl fumarate. And then also this app gives us the predicted probabilities to relapse within the next 2 years with a specific values, probabilities, percentage values. So here we can see that natalizumab is the best option with 43.7% probability to relapse, and then dimethyl fumarate follows with 51.1% probability. Also, what is important here is that we can have exactly the absolute difference between these 2 treatments. So here the absolute benefit of the methyl fumarate versus the natalizumab versus the methyl fumarate is almost 8%. And based on that, doctors may decide if they should prescribe this drug or not, because, for example, natalizumab is a drug with much more serious side effects compared to methyl fumarate. And when, let's say, the absolute difference between these 2 drugs is only 5%, then maybe the patient would not undergo for this drug, having in mind the serious side effects and the small risk benefit between these 2 drugs. As I also mentioned before, all these methods used for this tool can be used also to inform patients and doctors for any health condition. However, of course, there are limitations because a tool like that should include all the available treatment options. And here, as I showed, we have only 3 active drugs. And for relapsing remitting multiple sclerosis, there are much more drugs available. This will be possible when we obtain more IPD studies from randomized clinical trials, because we need at least 1 IPD RCT study for each one of the available treatments. And this is quite challenging because it's difficult to obtain that many IPD studies. But again, when we obtain these studies, we can enhance our model to include more treatment options. And of course, it shows how the potential of these methods, but it's not ready for use because validation is needed before a tool like that can be used in clinical practice. And this is something that we already work on. And also we work on adding cost effectiveness analysis that is also important for a model like that to be ready before it's ready for use. I would like to thank you very much for your attention, and I look forward to any questions you may have. Thank you.
Thank you, Konstantina. I saw one question in the chat, which is about shared decision-making at the doctor's office, but Yvette will address this first in her presentation, so maybe we can talk about this after. But for now, are there any questions to Konstantina and the tool she is working on?
Yeah, maybe just one question. You were saying that you only need one a study in order to get enough data from to get a second treatment in. Is that correct?
Yes. So in order to include a new treatment here in our model, we need one study that includes this treatment, that compares this treatment.
And the study doesn't need to have a certain length or duration or type of people that joined the studies?
Yes, of course, it needs to have patients diagnosed with relapsing remitting multiple sclerosis and the follow-up at least of 2 years.
Okay. And do you have any in the pipeline that you think would be okay for you to administer into the database? So that's going on currently, I mean.
So can you repeat the question? Sorry.
Are there any studies currently or just out of the studies that could be taken into account? That you
Yes, there are. Of course, there are many RCTs, but we have to obtain them.
Yeah, is that difficult? That was basically my question coming into that, because I know people like to keep the data to themselves. The pharmaceutical companies, how willing are they to supply this data?
Sorry, how are we?
How willing are they to supply the data to you?
Now we have some more data from one pharmaceutical company, so we will already enhance this tool. I think that as the time passes and we can obtain even more and more IPD, then the situation will be better.
Okay. Cool.
But already we have good news on that. So soon we will have information for more treatments at least.
Okay, great. Good luck then. Thank you so much for answering the questions. Yeah.
Thank you, Peter, for your question. I see another question by Francois in the chat. Can you explain the steps of validation that is needed? What does the validation consist in? Which resources are needed? Additional data, external data? If you could briefly reflect on this.
Yes, of course, the first step is to internally validate our model. So we need to we develop now methodologies to develop internally models that recommend treatments in a network meta-analysis concept. And the second step is, of course, to use external data, again, randomized clinical trials to validate externally whether the predictions of our model are good enough. So we need 2 steps, one internally and one externally.
Thank you, Konstantina. I see no more questions in the chat. Of course, if any questions pop up later, you can still put them in the chat and we can send them to Konstantina.
Yes.
Thank you very much. Then I would like to move to our next presenter, Yvette. Can you put up your slides while I introduce you? Yvette is a health economist working as a full-time researcher at Syreon, an independent research institute in Budapest. She also had a liver transplant at the age of 16 due to a rare genetic disorder called Wilson's disease. And she works with patient organizations and is the president of a youth group of patients since 2019.
Thank you so much, Ayla.
Go ahead.
Thank you so much. And I also have some troubles with sharing. I believe you see the wrong. Yes, now I'm getting it there. Good.
Yeah, there we go.
Okay.
Perfect.
Thank you so much for the kind introduction, Ayla. Good afternoon, everyone. As Ayla mentioned, I will talk to you about shared decision-making from my personal experiences as a patient and also from the researcher perspective. So before starting, a quick disclosure, all views presented are my own. But what is shared decision-making? And if you look into the literature, there are a good number of definitions of shared decision-making. For today, I chose the one NICE writes. So according to NICE, shared decision-making is a joint process in which a healthcare professional works together with a person to reach a decision about care. Shared decision-making involves choosing tests and treatments based on both the evidence on the person and on the person's individual preferences, beliefs, and values. It makes sure the person understands the risks, benefits, and possible consequences of different options through discussion and information sharing. So essentially, why do we need shared decision-making? And really, the basis where it's coming from is the inherited information asymmetry we have in healthcare. The healthcare professional has all the data, all the medical data and experience the patient might not have, whereas on the other hand, the patient is the one who knows their life and preferences, beliefs, and values the most. So we have to get these two parties together to sit next to a table and really deeply discuss all these matters to get into the best personalized treatment decision for that individual patient. Okay, but how does this look in real life? And I went to ask for our good friend, Google. I wrote shared decision making and looked for images on how this might look like if you ask Google. So first we have doctor and the patient measuring blood pressure, computer not even switched on. Now we switch to a notepad. Again, we had a doctor who's really paying attention to the patient, telling it perspectives. Again, patient-doctor situation. Now we have a computer and a notepad. Now we are sitting at a round table in a more informal way. They are all looking at a tablet. Another Apple product appears and they are looking at the tablet together and deciding on what to choose for the patient. And the most interesting one, and I want to really highlight this, is having not 2, but 4 people on the picture. We not only see the patient, but also someone who we might think is the caregiver of the patient. And we see not 1, but 2 healthcare professionals. So it can really be a team effort to choose the best available treatment for that particular patient. I want to continue with quickly talking about the benefits and challenges of shared decision-making. Potential benefits are obviously more personalized decisions, which may lead us to better health outcomes, or at least less risk of regretting past treatment choices from the patient. It might come with a higher satisfaction with care and a better doctor-patient relationship. And potentially, and I believe this is the most important, more empowered and maybe even more adherent patients, because if I'm not doing what someone ordered me to do, but we agree on a consensus, I'm more eager to follow that advice. On the other hand, we have a lot of challenges. And I will tell you a personal story of mine, which showcases how all these challenges can appear at once and really preclude shared decision-making in real life. So as Ayla mentioned, I am liver transplanted, and I got from a classmate telling me I have something yellow in my eyes to an intensive care unit talking to a surgeon about liver transplantation in just 1 month. So it was not ideal. I met the doctor that night. It was the most important medical decision I've made up until this point in my life. And I had to discuss it with a person I've never even met, so we didn't really have trust just yet. My health literacy at the time was questionable. When they told me I'm on the acute waiting list for a liver, I didn't even know what acute is, and I didn't dare to ask. And so did my parents. We didn't have enough time because of the emergency-ness of the situation, and we had no real options to choose from. It's either the surgery or death. So these are really main challenges, even if the patient and the doctor would like to discuss, that can appear. Now I would like to go into some myths around shared decision-making. And I'm not sure if you're familiar with the series of Mythbusters. It went on Discovery Channel in Hungary, and I really want to debunk some myths around shared decision-making. And the first one being, not everyone wants shared decision-making. Actually, a review of the literature of multiple studies found that since the 2000s, around 70% of patients want to have more information and want to have a more active role in deciding on their care. So that's debunked. Second one, not everyone is good at shared decision-making. And this one is partially true. We are not born with the skills to be good at shared decision-making, but studies have found that the use of so-called decision aids, which help the patient, which are tools that help the patient and the professional to really systematically discuss all the points that should be discussed. It can be just a document with a list of questions, or it can be a more computer-based, more interactive tool. But these decision aids really help to make the patients more active, more willing, and more capable of getting into the decision-making, as well as the doctors. A very common one, shared decision-making takes too much time. Actually, again, a review of the literature, of the scientific literature, found 10 studies which measured the time spent with regular clinical practice versus shared decision-making. And of these 10 studies, 6 found no statistical difference, 2 found shared decision-making was indeed a bit longer, and 1 found that it actually took less time than standard clinical practice. Fourth and least, shared decision-making is not compatible with clinical practice guidelines. Clinical practice guidelines are the source of evidence-based decisions in healthcare, and some may say that including the patient and the patient's perspective will not end up in the most optimal decision in terms of following the clinical practice guidelines. Whereas study found that doctors had really no challenges or problems with adopting both following clinical practice guidelines and shared decision-making. And as a matter of fact, in more and more clinical practice guidelines, before an important treatment decision, it is noted for clinicians to check for the patient's preferences, beliefs, and values on that matter. So what should be discussed at this table when we come together? And I summarize it in 3 points. And again, I will come with a personal story of mine. So for the last 13 years, I've been on immunosuppressive therapies. And basically, I have 2 choices at this moment of time. I can either be on monotherapy, getting treatment A only, or I can be on combined therapy, getting an additional medicine for the one I'm already taking. Monotherapy, and first I needed to understand what are my risks and benefits. So for monotherapy, it might help my immune system to fight with infections more effectively. I have chronic infections with quite heavy burden on my quality of life, in my ears, on my skin. So it's quite inconvenient, although not really coming to my survival. Whereas combined therapy might give me longer graft and thereby overall survival, which is pretty important for me. But on the other hand, it may have more potential side effects. So getting all the medical information, then comes the practical considerations, the mode of administration and costs. In terms of costs, there are no big difference for me. Both are covered by my health insurance. But in terms of mode of administration, there's a slight difference which may seem insignificant. However, it may not be for the patient. The monotherapy is a once a daily treatment, while the combined therapy is a twice a daily. And here comes into the picture my beliefs and values and perspectives about the other two columns. So how do I interpret, how do I weight these in my own perspective for my own life? And where I got to up until now is I do have a strong preference towards the once daily treatment, and I really don't like these chronic infections, and I want my body to be able to fight them more. On the other hand, survival as a young person is my top priority, but I'm also afraid of even more long-term side effects. So I'm at this point right now. Unfortunately, this wasn't a shared decision-making, so I had to bring all these together for myself, but I'm really hoping for a future that this decision can happen with my healthcare professional. And how HDX and how real-world data can help in this is really at the risks and benefits. Should I know, for me, with my stable liver function, with the disease I had, my personal risks of or personal benefits of a longer graft survival with combined therapy, it would be really helping the decision to make. So I believe we can add value on more personalized risks and benefits and the more robust database, and not only the studies that were produced years ago. So I have two take-home messages for you. The first one being that empowered patients are really the future of healthcare. So anything helping with that, we should be advocating for it. And shared decision-making definitely does. How can we make shared decision-making becoming the norm? Actually, I believe we need two main important components. One is a change in the attitude of both the physician, but partly patients as well. And we need helpful tools which are truly helpful, not only reliable in terms of the data and evidence presented, but also user-friendly. So I'm hoping we will get closer to that by the end of this workshop. Thank you so much.
Thank you so much, Yvette, for sharing your personal story. I don't see any acute questions. Just a practical matter. Are the slides available after this session? At least I can send out the recording on request. I think the slides are also available. Is that correct, Yvette?
Correct. Yeah.
Correct. Okay, great. I don't see any other acute questions, so I say let's take a break. We have heard a lot already, and let's come together again at 2 o'clock. Thank you.